This deep dive is adapted from a clinician-written article on Mentalic and brought to life in audio for therapists who prefer listening on the go.
And we're really excited to dig into this one. The piece was written by Sylvie Saxena, that's an MBA, LSW, a certified clinical trauma professional, and a certified oncology social worker.
And since the article does come from Mentalic, it probably helps to know it's a clinical intelligence platform. It's, designed specifically to make complex clinical documentation and reflection a bit more manageable for therapists.
Which is exactly what we need, right? Some way to standardize the inherently messy subjective data we get from clients every single day.
Okay, let's unpack this. We all have that moment in the session. A client starts describing just systemic chaos.
The overload.
Yeah, high demands at work, maybe low control over their environment, a family crisis on top of it all. They feel completely overwhelmed, exhausted, and it's a powerful story, but we as clinicians can struggle to take that qualitative, that subjective chaos and turn it into something measurable, a benchmark for treatment.
And that is the exact problem. The perceived stress scale, the PSS-10, is built to solve. Its whole value is right there in the name. Perceived stress.
Ah, okay.
It completely shifts the focus away from an objective checklist. It doesn't really care about the divorce or the new job or the demanding boss. It's intentionally designed to measure the client's internal, subjective experience of all that stress.
So it's not tracking the events themselves, but how unpredictable, how uncontrollable, and how overloaded they feel their life is because of them.
That subjective lens is absolutely everything, because it's precisely those perceptions, that lack of control, that unpredictability, that are most strongly linked to anxiety, depression, and all the physical health symptoms that follow.
Right. So we're not measuring life events. We're measuring the internal resource demand mismatch.
That's it.
I think that's the most meaningful insight from the research here. If we're going to use the PSS-10, we have to start with the understanding that the score, which runs from 0 to 40, it should never be treated as just diagnostic or standalone.
Absolutely not. The primary, really the sole value of that number lies entirely in the clinical context that you, the therapist, bring to the interpretation. The categories, low, moderate, high, they're just guides.
They just tell us what's statistically typical.
Right, not what is clinically meaningful for this specific person sitting in front of you.
Let's ground that with a real example, because I think this is where clinicians can easily misstep. How can a moderate score actually be more concerning than a high score?
Okay, so imagine client A. They scored 24, which is on the upper end of moderate. Now, objectively, this client is relocating across the country, starting a huge new job, finalizing a messy divorce, and they've lost their social support system.
Okay, so their life is, by any objective measure, systemically incredibly difficult.
Exactly. So for client A, a 24 is, it's an expected stress load. It validates the immense pressure they're under. The conversation then becomes, okay, how do we manage the reality of this high stress?
Right. Now let's contrast that with client B.
Client B scores an 18, mid-moderate. But their external life looks stable. Predictable job, supportive family, they're financially secured, no major losses. So why are they feeling moderately stressed when the objective load is low?
That 18 is suddenly highly concerning.
It's a huge red flag. It flags a potential discrepancy between their internal distress and their external reality. That score isn't just measuring stress anymore.
It's measuring a potential internal process.
It is. That 18 could suggest, denial or a chronic difficulty integrating their own emotional distress, maybe significant emotional suppression, where they're cognitively just minimizing their own feelings.
So the score becomes a jumping-off point for a deeper clinical conversation about avoidance, maybe, not just a conclusion about their stress level.
It's an invitation. An invitation to explore an internal landscape that just doesn't seem to align with the environment.
That really reframes the PSS-10 as a tool for identifying and validating that misalignment. That's powerful. So to give clinicians some confidence, let's quickly review the mechanics. It's a 10-item self-report scale, right?
Yep, 10 items reflecting feelings and thoughts over the past month on a 5-point Likert scale, 0 to 4. And it's quick, about 5 minutes.
And that past month time frame is important.
It is, because it averages their experience out. It smooths out the peaks and troughs of daily life. And speaking of scoring, we really need to address that technical detail that trips people up when they're scoring by hand, the reverse score items.
Okay, so why do 4 specific items, I think it's 4, 5, 7, and 8, need to be reverse scored?
Because the PSS-10 is holistic. It can't only ask about negative feelings. Items 4, 5, 7, and 8 are the positively worded questions.
Oh,
They
okay.
ask things like, how often have you felt that things were going your way? Or how often have you felt able to control the important things in your life?
So those questions are actually measuring the client's perceived coping ability. They're available resources.
Precisely. So if a client answers very often, to feeling like things were going their way, that answer should reduce their overall stress score, right?
Right.
If we didn't reverse score it by subtracting their response from fours, their high score on a positive item would actually inflate their total stress. It would make them look more stressed.
Which is the opposite of what's happening.
Exactly. Reverse scoring just ensures that higher perceived coping correctly lowers the final perceived stress score. It's what keeps the scale valid.
That detail is so critical for clinical confidence. Okay, so let's talk about ongoing application, because this scale isn't a one-and-done thing. It's designed for repeated use to track change. The article uses a great case study, Mary.
Oh, Mary is so relatable. She's a 38-year-old single mother. She's in a demanding leadership role, and she's also handling the increasing health needs of her aging father. I mean, it's classic systemic overload,
And when she first comes in, her PSS-10 score is a 30.
which puts her squarely in that high-stress zone. It completely validates her reports of chronic irritability and, trouble concentrating.
And that score, that 30, is invaluable. It's no longer just an abstract feeling of being overwhelmed. It's a concrete baseline.
Yes. For Mary and her therapist, the goal shifts. It goes from a vague, I want to feel better, to a collaborative, measurable objective. Let's work to bring that 30 down to a more manageable 16 or 18.
And what kind of intervention are we talking about here? How does that link back to what the PSS-10 is actually measuring?
Well, the therapist uses trauma-informed CBT, which is just brilliant here. Think about it. The PSS-10 measures uncontrollability.
Hmm.
Trauma-informed CBT specifically targets skill deficits in things like emotional regulation and boundary setting, which directly counteract that feeling of helplessness.
So by teaching Mary how to say no, how to prioritize, how to regulate her own nervous system, the intervention is directly improving her perception of control.
Her perception of control and predictability over her life.
Yeah.
So if the work is effective, we should see that PSS-10 score drop right alongside her reported symptoms.
And Mary uses it every 4 weeks.
Every 4 weeks. And this is where the tool facilitates truly measurable outcomes. We have to be able to show that the therapeutic work is translating into lower subjective stress over time.
Which can be a real administrative headache.
It can be. Which is why tools that automatically measure these outcomes and assessments over time are so essential. The mental progress tracking tool, for example, is designed to do just that, to track this data seamlessly, turning those recurring assessment points into measurable evidence of change without forcing the clinician to sit there and manually chart everything.
That makes the metric useful in the session and, actually manageable outside of it.
Yeah.
Now, before we move on, we should briefly touch on the PSS-14. Why are we so focused on the 10-item version when a longer one exists?
It's a classic case of efficiency meeting rigor. The PSS-14 adds 4 items, and they tend to focus on more nuanced aspects of self-efficacy or specific coping actions, which is great for research.
But for busy clinical settings.
For busy clinical settings, the PSS-10 maintains nearly the same high level of reliability and validity.
So we're getting, 90% of the clinical value in half the time?
Pretty much, yeah. The PSS-10 is just faster and easier to administer repeatedly, which makes it the standard choice in a practice where time is always a factor.
Quick pause. If tracking consistent progress, managing metrics like the PSS-10 over multiple sessions, and just staying on top of documentation amidst a high caseload feels familiar, Mentalyc is here to help. It supports your documentation and your clinical judgment while staying fully IPABON and SOC2 compliant, giving you more time for the high-quality clinical conversations we're discussing. You can explore how Mentalic supports therapists at Mentalyc.com. Welcome back. So we've established the PSS-10 is quick, it's efficient, it's versatile. Let's reinforce the scale's legitimacy for a moment. Beyond the subjective context, what does the research actually confirm about its foundation?
Oh, it's rock solid. The PSS-10 is evidence-based and shows really strong construct validity. What that means clinically is that when a client scores high on the PSS-10, those scores correlate strongly and reliably with measures of anxiety, depression, and even physical health symptoms.
Like tension headaches or GI issues?
Exactly. It confirms that the client's internal perception of stress is a reliable predictor of their overall mental and physical well-being.
And what about applicability? The source mentions it's used across a pretty broad age range.
It is, yeah. The PSS-10 is suitable for adolescents, generally from age 12 and up, and for older adults, The language is simple, it's accessible, but, versatility always demands clinical thoughtfulness.
What do you mean?
Well, with an early adolescent, we might need to actively normalize the concepts, right? Make sure they really understand what we mean by how often they felt irritated or unable to cope.
And for older adults, the administration itself might need to change.
Absolutely. We need to be mindful of potential sensory or cognitive limitations. We might choose to do a verbal administration instead of just handing them a paper form just to ensure they're interpreting it accurately.
Mm-hmm.
It's still a powerful tool, but the delivery method has to be adaptable.
Okay, now let's pivot to the constraints. The PSS-10 is brilliant for what it does, but it's not a comprehensive assessment. What are the key limitations we need to keep in mind?
There are three non-negotiables, I'd say. First, the PSS-10 does not assess specific coping mechanisms. We get Mary's score of 30, but we don't know if she's dealing with it through journaling or running or binge drinking.
We still need the interview for that.
You still need a thorough interview. Second, it doesn't directly assess core symptoms of specific disorders. It correlates highly with anxiety and depression, but it is not a diagnostic tool for them.
So it tells us they feel overloaded, but we still need something like the PHQ-9 or GAD-7 to actually confirm clinical depression or anxiety.
Correct. It's a magnificent screen for global distress, but it doesn't pinpoint the specific pathology. And the third major limitation goes back to that 4-week window you mentioned.
Because it averages things out.
Right. It can miss acute short-term changes. If a client had a major crisis, a sudden panic attack, an immediate job loss 1 week ago, the PSS-10 averages that acute stress with 3 previous weeks of maybe moderate stress. The score might come out looking moderate, and you can miss an acute risk factor that needs immediate attention.
So it confirms why it has to be used in conjunction with other tools and our own clinical judgment. It's not the whole picture.
Never the whole picture. It's a key piece, but not the whole puzzle.
So that brings us to the most practical takeaway for today. Let's go back to Mary's 30. How do we use that result right there in the room to enhance the treatment?
You use that number to concretely validate the client's internal experience. When Mary sees that 30 on paper, it externalizes her chaotic internal world. It's no longer just this nebulous feeling.
It gives her a concrete, collaborative focus for treatment planning.
Exactly. It allows the therapist to say, look, the data supports how overwhelmed you feel. So let's focus our psychoeducation on the 3 things this score measures: feeling out of control, feeling unpredictable, and feeling overloaded.
So it guides your immediate intervention priorities. If the score is that high, maybe you start with emotional regulation skills or boundary setting exercises before you even touch deeper insight work.
That is the utility of it.
Yeah.
It moves the conversation from the abstract, I need to feel better, to the concrete collaborative goal of, we are going to track the reduction of your perceived uncontrollability. That is so empowering for a client.
And that leads to the final provocative thought. We've spent a lot of time on the high scores, but let's circle back to the low to moderate scores, especially the really low ones, the 0 to 13s.
Yes. We have to challenge our own assumptions about a low score, especially in a client who, based on their life circumstances, should be extremely stressed. We have to ask, what does a low score signal when reality is overwhelming?
It sounds like a flag for potential denial or emotional disconnection.
It could be. I mean, it could signal genuine resilience and incredibly effective stress management, and we should celebrate that. But if a client intellectually describes their life as a constant dumpster fire, yet they report a PSS-10 score of, say, 8, then misalignment is a diagnostic warning sign. It suggests a mechanism of emotional suppression or minimization is at play, and that PSS-10 score becomes the key piece of evidence that warrants deeper exploration. And that exploration of the disconnect, that is often where the real nuanced work actually begins.
That's a powerful directive to bring back to our practice, that the score is just as revealing when it's low as when it's high. If you want support translating your nuanced clinical insights from these PSS conversations into documentation efficiently, the Mentalic AI Note Taker can help you focus more on applying that clinical judgment and less on the administrative work of detailed record keeping.
It just supports stronger, more focused care.